recording.
Welcome everybody to the January 30th version of our PCI community calls. We're really pleased to have all of you join us, but most particularly to highlight our speaker, Katarzyna Wac. She is an amazing person working in a very important field of quality of life. I actually came across quality of life about 20 years ago with the work that was being done when I was involved with the quantified self. And so when I met Katarzyna, I really knew that she was doing some important work in the academic area. So Katarzyna is the leader of the quality of life research area at the Geneva School of Economics at the Center of Informatics at the University of Geneva in Switzerland. And also since 2015, she has been working with the Department of Computer Science at the University of Copenhagen in Denmark. So you see this interlink between economics, computer science, and actually health. So there's this important connection with the Stanford University School of Medicine, which actually brought us together. She's originally from Poland and got her bachelor's and master's at the WHOQOL University of Technology in Łódź, Poland. WHOQOL University of Technology in Poland, and a Master of Telematics in 2004 from the Netherlands, and her PhD is in information systems from the University of Geneva. I just want to say that she herself is an amazing person. Far from being a prim and proper academic, she has a full life. She enjoys life. She's a wonderful example of actually living quality of life. And that's, I think, makes her unique in being able to span so many disciplines, as well as demonstrated in her day-to-day living. So over to you, Katarzyna.
Lovely. Thank you very much for this introduction. I'll try to live up with the expectations here. I'm going to share my screen. I have a talk, and I have going to take you on a journey, a quality of life journey, in which I do hope you are going to also position this interesting research area in the context. And I also realize I may have named my presentation, my event today better, because actually we're going to measure quality of life of, as I would point out, internet-centric people, right? So it's not just the people-centric internet, but we also like the way we are acting with technology, the way we're using it for daily decision-making, and the way it's helping us to improve our quality of life. It's very crucial to our day-to-day functioning. And another subtitle is "What is always speaking silently is the body," where I'm going to point out how we're going to measure the body and measure the quality of life through the measuring of the body. And the work here presented has been done in multiple research projects in collaboration with Geneva, Copenhagen, Stanford, and many more colleagues. So, but let's start with the use case of our individual with whom we're taking care of and whom quality of life we would like to assess. So here's a patient, female, 69 years old, has type 2 diabetes for many years right now, heart attack also some time back, and hip fracture replacement. So has a problem walking, but loves cooking and too much loves carbs, which you can imagine it's not that good when you have a diabetes. This is her healthcare kit. So it's a kit for measuring glucose. It's very sporadic measurement of the glucose, and she doesn't even have this particular diary. And you know that something about diabetes, you should note your diaries with respect to your food and medication intake, insulin, but she's very stubborn, and she's pointing out she's not going to have it because she knows her body better than anyone else. The same applies to her medication, which she's just adjusting herself. There's a medication for cardiovascular disease, there's medication for diabetes, and there's maybe other medication that she's just adjusting himself. But this is her excellent cooking, and it's a Polish cooking. And this person is super stubborn. I know it because it's my mother. And I guess there are many more this kind of patients surrounding us, and they can be our mothers, our parents, our grandparents, or family members who are having the so-called comorbidities and also are quite stubborn. And they are not the only ones. Unfortunately, from research perspective, it's more and more evident that our behavior patterns contribute to more than 40%, and some literature speculates that 60% of our future health state and quality of life is resulting from day-to-day repetitive behaviors, which includes smoking, poor diet, physical inactivity, alcohol, and some other risky behaviors. That's unfortunate, but that's what is the status. So overall point is that actually what I'm going to tell you, that we are not really having a really good measure of behavior, and we cannot measure it, we cannot improve it, right? So there is a line of research to which I'm contributing, and the keywords which we may find out from perspective of using technology and computer science skills and tools is stemming from this looking into genome in the past. Now we're looking into behavior and behavior and behavior markers and digital biomarkers, which I'm going to present to you today in order to measure better this daily life behaviors and how do they, and then model how do they contribute to our health and quality of life in the long term. But before we get into the behaviors and behavior markers and technology, I would like to have a quick view on the current taxonomy of the data sources which we have in context of health, behavior, health, and quality of life. So starting from left, we have patient-reported outcomes and specifically self-reported outcomes, which is a set of measures where the patient, the individual, is reporting on their behaviors. For example, the doctor will ask, how did you sleep? Did you take your medication? And in many cases, it's either just more like a natural language expressions from which the clinician or the expert will derive some specific thresholds, or it's a validated scale, like a questionnaire based on which these behaviors or symptoms or other aspects of life are evaluated. And then I moved into the right side when we have a clinician reported outcomes, where the clinician may also have some specific observation or do examination or touch the patients and then add it to this overall clinical decision making. Then the next box is performance reported outcomes, where we have a patient or individual undergoing some tests like treadmill test for cardiovascular disease, or 6-minute walk test, maybe you heard about this, or some mental tests with respect to their cognitive abilities or other abilities. And the last subset of this particular non-patient reported outcomes is technology reported outcomes, which according to taxonomy of the authors, original authors, this paper, and then we classify everything coming from technology, including blood tests, x-rays, and scans, pictures, and additionally to, as we recently added, wearables and smartphone apps, passive assessments, which are not mentioned in this original paper. Then I will just quickly say what's in the middle. In the middle, you may, is observers and proxies are the persons around the patient. And in many cases, you can think about for example, a child being a patient, and then the parents are a proxy for reporting of what are the specific behaviors and health outcomes, or what happened the night and why we are getting to doctor, or persons with cognitive impairments, which they cannot report on behalf themselves. So then we have family, friends, and nurses or clinicians who are reporting on behalf of the patient. So here is the overall view on the data model of different data sources which are then taken into consideration for clinical decision making. And then whenever later on I will talk about pros, I will keep in mind the fact that it's something self-reported by the patient, by the individual. And then when I talk about TechRose, there's something which is coming from technology, like a passive data source. For recall, maybe I'm going to talk about the self-reports. This is one of the evaluation. It's a validated scale for sleep. So imagine you would come to the doctor and complain about his sleep patterns, and then you will have these questions, in total 12 different questions, and evaluating your usual bedtimes, number of minutes you slept, and troubles like too cold, too hot, or some additional aspects of waking up too early, or waking up too frequently, or not being able to sleep, and these kind of things. And the challenge is that the usual question like this would be during the past month. So the so-called recall period is the last month. So imagine that you come to the clinician in the moment when you were really sleeping very badly for last week. Your answers may be very biased, and you may be very biased in the way you answer, and the answer may not represent this past month. So this is like a resolution, the current resolution of your sleep assessment. And this is related to other particular shortcomings of this self-reported outcomes, this patient-reported outcomes. They're generally very infrequent, they're very subjective, memory biased, social acceptable, and very qualitative. And the big picture is, I don't think this audience needs a further explanation. We have technology almost embedded in our wrists, right? And according to our really even right now old, by now very old research from 2011, actually, even the phone was around back then 88% of the time next to us, at least in the same room, while now we have many more technologies available, many more so-called wearables, digital health technologies. And this is a snapshot of my own, out of curiosity, I have classified 438 different wearables which were available in 2018, and there is a whole book chapter describing different aspects of what these devices measure. But here, what's interesting is where they can be put on the body, and what function, what kind of outcome they provide, what they can measure. So fun fact is that there are also specific devices to measure golfing and playing piano, and another ones. Actually, when you think about, like, for example, feet, there are 12 different devices to put on the feet. And I don't think we'll be able to walk after that if you put all the 12 devices, but they exist and they measure different aspects of physical activity or mobility. So you can imagine that the bigger picture is that with these different technologies, we would like to have a much more objective, quantitative, longitudinal, continuous, non-judgmental, sensor-based, frequent and context-rich information, and specifically what happens in between the visits, and what are these behaviors which we'll care about, and which may be indicator of specific disease, but they can be also related to a treatment, right? The progress of the treatment. I would like to also now put in context the research on quality of life. I get this question a lot, and I think for this particular diverse team we are here on the call, it's very interesting and important to put it in the context where, like, what's defined as a quality of life? Where do we stand from perspective of different theories? So there is a quality of life defined from psychology perspective, economics, developmental sciences, policy, and medical sciences. And then here we have different types of theory, construct, and the measure. So I will just say, in GRO, on psychological side, the quality of life relates to our particular feelings, and the feelings, and well-being is also another keyword in which is being used. Happiness, but affect, feelings, well-being, and this kind of evaluation. Then from economics, here it comes. Some of you may be interested in evaluating GDP, GNP, households income, and linking it to the population level to the evaluation of quality of life, how well we're doing. Then developmental sciences, looking at the Human Development Index. But then also maybe some of you are interested in policy sciences and know OECD Better Life Index. Actually, we had in the previous calls, working with Maylene, we had somebody from the OECD looking into Better Life Index and how do we evaluate quality of life at the, again, population level. And then the last one in which I contribute and I would like to tell you more about is the more medical science aspects, where we have definitions of, there is a lot of sickness, as I was point out, but there's also quality of life defined from World Health Organization and from health and behavior organization perspective, yes. So here we have, the framing is that I'm going to follow with in this particular context of medical sciences. And then there's a lot so-called instruments. So the quality of life as a concept is evaluated by self-reports, and this is an example of 100. You cannot read it, that's not the point, but there's one paper pointing out there are 159 different instruments. Each instrument, imagine it's a questionnaire in which you need to fill up in order to evaluate your quality of life. At the end, there will be some algorithm or way of scoring it and then giving you either diagnostic or some risk assessment value, right? And then another paper pointing out how many new instruments or tools, they call it tools, how many were developed, how many are updated, and we are drowning in this particular beautiful research on psychometric values of how do we translate of what people feel into how they express it in words. But what I'm going to try to point out is there's much more to be help with technology side. So starting with quality of life, I told you I'm following the medical sciences, and then even more focused. One of all this 159 mentioned the other slide, there was World Health Organization definition, and then the big picture is that quality of life is then evaluated for the healthy individuals, so not in specific sickness, in context in specific sickness or disease. And there are 4 domains: physical health, psychological, social, relationship, and environmental. And inside there are different, they call it facets. But what we look from like more computer science perspective, we look like what are these variables, what are these features which are then contributing to quality of life. And then the overall definition, individual perception of their perception in life, and in the context of the culture and the value system in which they live in relation to their goals, expectations, standards, and concerns. So the way the questions are being asked and the way we evaluate these particular variables are related to what has been expected and what's the expectation of the individual. And then health. World Health Organization again, but 1946, that's a quite old definition where World Health Organization defines it as a state of complete physical, mental, and social well-being, and not merely the absence of disease and infirmity. And this definition has been very much criticized for this complete, the keyword was the complete physical, mental, and social well-being. So imagine you have not been sleeping today quite really well, and you may not be in its complete physical health or mental and social well-being, and then you are already you may be classified according to this definition as not being healthy. So a set of scientists came together quite some time ago, already in 2011, on the definition, the new definition which we follow is more like ability to adapt and self-manage in the face of different life contexts, like social, physical, emotional challenges. So how do we do that? So another theoretical concept, which maybe some of you know, and they help me to define further, how do we define these different data sources coming from wearables and smartphones, and make sense out of them towards the health and quality of life. Starting from the left to the right, there's a view on an individual in context, and then we start from looking at the biological and physiological variables, then symptom status and functional status, and then we go to the right when there's more this self-reported, the health perception and quality of life perception, knowing that the characteristics of the individual influence all these different boxes, as well as the environment the person is. So again, when you think about the quality of life and health perception, it's the pros, it's the self-reports. And then when you think about the biological, physiological, and functional and state symptoms variables, then I'm going to show you how we are going to quantify them via this tech rows, these different technologies. Not everything is measurable, not everything is directly measurable, not everything can be made sense of, but there is a lot of hope in this domain. And then another small methodological note with respect to these different data sources from which we make sense is we have this living lab, and the infrastructure based on which we collect data is called QoL Lab. And nevertheless, we do not just collect this data from the log, the component which is harvesting data from existing hardware and the smartphone usage. It's called QoL Log. But as you can see, it assures external validity and it's quite objective passive data sources. But in order to have more view of what's really happening between the visits, what happens in the wild, we talk to people. We do talk to people on a regular basis. We do interviews. We have diary-based approaches, data construction method DRM, or ecological momentum assessment, or experience sampling method, which is this little pop-up on the phone, which is asking to label existing, like right now, the momentary state, like how do you feel right now? How much pain do you have? What's your fatigue level? And then that's where we are collecting this much more subjective, but also data sets where assuring different levels of validity. So if you can imagine, we are making sense out of this qualitative and quantitative data sets. And just to say how much we have done so far, it's 13 out of 24 variables in different research projects. So my dream is one day I'll stand in front of the audience and say, okay, today we're tackling and computational modeling 24 variables, including all this important ones, but also quite challenging, like for example, sexuality or body image, which is very much subjective concept, right? But then also I would like to also say that my vision for the lab and the way I'm leading different projects is like having much more correlations between these different variables and not just single silos of different models, because everything is connected, right? So this dimensionality is exploding, and that's right now I'm tackling this in different projects. Making sense out of this, as I said, in different projects, getting into this behavior management approaches, and hopefully together with all different collaborators, because I'm not a medical person, so I work with in different projects, European national projects, in different end user organizations, and then we're hoping to change this particular curve, bend the curve of quality of life, and increase, thanks for the self-management and our data provided, increase somebody's health in the long term. But actually today I would like to snapshot in really high level helicopter view, qualitative summary of the whole area of quality of life from my perspective. So again, medical, again through the body, seen from the body, and how did it happen back in 2019, end of 2019, I got into discussion when I was at Stanford. I got in discussion with Sharon, who is a medical doctor, and said, okay, we're going to write a book on quantifying quality of life, and we are going to, for each 24 variables of quality of life by what organization, we're going to invite experts to write a chapter on what's the state of the art in quantification of this particular variable, and then where's the, so what's the state of the art and what is the future? How do we get into future? It has been supported by for open access by Swiss National Science Foundation. So now I'm presenting you the view that going beyond my lab, because I could talk for hours about my lab research, but who cares? I mean, in a sense, I really want to tell you where is the field standing and where we can maybe together collaborate and contribute. So again, you remember I was telling you how we see the body. So there was a physiology, biophysiology, and then there was symptoms, and then there was a functioning. And then also there's individual characteristics and then context. So that's the context is this environmental aspects. And then inside functioning, we have been defining very specifically from computational perspective, like what's the functioning, is the physical functioning, psychological functioning, and social functioning. And the social functioning, we name it interaction, as functioning with other humans. And then we defined a set of devices in the sense of the input through which this input is collected. But then when we look now, the book is going to be released in a month. And then we did this qualitative coding of everything what has been written by all these beautiful experts. And then looking into what has been this biophysiological data sources based on which these different 24 variables have been evaluated. And in many cases, there was temperature, for example, and heart rate. And that was, the temperature was a bit of a surprise. Why temperature? Because you may say, okay, how do I define the temperature correlated to, I don't know, yeah, okay, emotional affect. There can be some increase of body temperature or so negative affect, but maybe for some variables doesn't even make sense, right? Like work capacity or something. So yeah, anyway, we think also it's because of the historical point of view of the temperature sensors. They're much more longer and much more available earlier than the heart rate sensor, for example, which is now embedded in any wearable. Then it comes out as a contributant to how can we assess different aspects of quality of life. Then we go into functioning. So that imagine the body without interaction with others. So just the view on the body from perspective of physical aspects of sleep or physical activity. So accelerometer was the most frequent, the most used data source for assessing different aspects of mobility, activities of daily life, home environment, transportation usage, you name it. And again, it's really gross, like a view, a helicopter view on all this 24 chapters and 24 variables based on which the authors were describing what technologies are there for quantifying this variables, right? And then for interaction, there was a lot of discussion on social activity. Although the subsample of there are only 3 chapters for social interaction, then there is less word cloud and there was less data to work with. And in the context, a lot of location. And the location from perspective of either GPS location or not self-reported, sorry, GPS location, I want to say Wi-Fi, 3G, cell ID, whatever. Some of you may be more familiar with the different methods for quantification of location. And there's also light and temperature and other aspects, air quality, for example. But that's a very high view. And then I'll have now another view on this particular book and everything what has been contributed in. And now I make a table and I said, okay, now for all these 24 variables, again, physical health, psychological health, social relationship, environmental, what are the specific self-reports? So the first row will be, I have been motivating as an editor of this book, co-editor of this book, motivating the authors to really point out what is the gold standard right now? How do people self-report on the specific aspects of their daily life or psychological health or social relationships? And then here, what I'm summarizing, I'm really again going the helicopter view, how many self-reports exist in this domain. And for some domain, like when you go into physical health, psychological health, social relationships, for some domains, there's 2, 5, 6. I was really surprised to see that there were, for example, for thinking, memory, concentration, there were 44 different ways of self-reporting your cognitive evaluations and cognitive skills and cognitive performance, but also including some tests, right? So you do some tests either in digital form or in their paper and pencil, and they will be timed, and there will be some answer of how good is your memory or what are your cognitive skills. And then there was in environmental aspect, not so many self-reports, right? So this data may come from somewhere else. There may be based on geographic information systems or policymakers, or like here in the city of Geneva, there will be like view on transportation or safety. It's not the person who would be then asked, and that's maybe also a shortcoming, right? And then now I'm presenting more like shadowing of different boxes of the specific cells in this table, where I was where we've been actually coding, both of us, we've been coding the view on how much technologies exist, how many different technologies exist from the perspective of different modalities, right? So again, you remember physiology, functioning, interaction, and context, and which is the emphasis for which specific variable contributing to quality of life, which is the specific emphasis on which particular modality. Where is the data coming from for quantifying this particular variable? So in the first box, when you look in big picture of physical health, there's some physiology and there's functioning and interaction. Then psychological health gets more emphasis on the interaction, as you can imagine, and then going to even more emphasis on social relationships. And then environmental, as you can imagine, there's also interaction and so much more emphasis on context. But thanks for this high level view, you can also see where the research gaps, right? So why don't we, for example, link physiology to environmental aspects? There's not yet much research in this domain, but it's maybe very important and very beneficial to have these evaluations. And the point is that what I learned also, and that was being said many years ago by a philosopher, Norman Brown, what is always speaking silently is the body. So the physiology, the functioning, the interaction in context, and also the choice of the context could be really the signals we are looking for. And that's where I also would like to point out, because part of this research also made me aware how much effort goes into evaluation of videos, visual, verbal, vocal assessments of some kind of lab-based tests where deep learning, machine learning techniques are used for evaluation of, for example, face expressions and interaction aspects of rapport between the individuals, having social relationship or something. And then I feel, seeing this, I also feel that there could be much more emphasis on this physiology, functioning, interaction aspects. However, of course, there's huge aspects of privacy and security and not getting into more ethical questions with respect to this. So what about the individual? First of all, I wanted to get back to my mom, who was such a stubborn person. And here you see a snapshot of her 3 days of continuous glucose monitor, which was one of the biophysiology sensors. And you can see it goes out of the charts for some days. It was just three days of a snapshot. Unfortunately, this technology is not available in Poland, so I only got 3 days of data, and then something happened with the sensor. And if she would monitor as she's doing it maybe 1-2 times a day, she would totally miss all the highs and lows, and that's scary in the long term. That could be really bad in case of specifically high glucose for too much time. Also, we know that it's now related to some damages in the brain. And then another good thing was that she got a new medication. She was sleeping for 7.5 hours. She got a new medication, and then she was, as you can see here, between March and August, she was waking up, going to the bathroom, and then she was reporting that she cannot catch up with her sleep. And so you have see some few months of the data where sleep is not reaching 7.5 hours in total sleep duration. So if you could well sleep, so communicating to the patient, to the clinician, and getting back on her own old medication, the cardiovascular one. So that's like a more successful story. That is more for self-management. But I would like to point out that in our research, it's not just that we are collecting all this data, seeing individuals, these smartphone-centric individuals, the internet-centric individuals as the data sources, but we are also thinking about how do we encode in our algorithm and how do we manage these human factors. And a lot of learning came when I was again at Stanford, and I was interviewing 200 chronically ill patients and at the clinic. And the basic question was, how do you use technologies? Specifically, I was pointing out to their smartphone. And if they had a wearable, then I also would say, yeah, how to use this particular technologies for your own health. And then there will be around 20% of the individuals who say, I don't even talk to me about this. I don't mix my phone with my health. It's all in here. I don't want the phone reminds me about my disease. And I have got, and this particular person was pointing out, I have got a Fitbit as a gift, and I dropped it because it was not good enough for me. So there is around 20% of population which will not be aboard with respect to use of technology, even if they have a newest device in their hand. Then around 20% is skeptical, and I think the biggest thing is the privacy, and I see it even more now interviewing patients here in Geneva. I see it even more as really the breaker from perspective of not only the assurance from our side about the security and privacy of the solutions, but also education. How do they understand how they perceive the security and privacy of different devices and solutions? And then the complications, complicated, and not the techie, it's inaccurate. Also, some persons were comparing to different devices, Garmin, for example, and Fitbit, and dropped it. And then the rest, 60% of the population is very much using to their best abilities different devices and solutions. However, there's always some challenges, and I learned a lot about. I got a lot of back to fix from behalf of Apple, Google, some apps. I got a lot of feedback on what needs to be fixed in this app and that app. But nevertheless, overall, in summarize, this particular human factor is influencing the more positive use of technologies for own healthcare. It will be, how does it make people feel? How does it make people feel? So the overall thing will be, if the interface, if the way it works is too complex and it makes them feel they cannot take care of themselves better, they're going to definitely drop it. And from our own perspective, the drop off timeline would be 2-3 weeks, after which they're not going to use it anymore. So if you look at the paper for more details, you can see all the quotes and supporting thinking behind the theories of self-efficacy, how the technology helps them to believe that they can take care of themselves better, they are in control. But nevertheless, overall, I'm so excited about this domain, but I still do not have a fully answered question, like, can it work? As I'm saying maybe because we're on the way. And the last thing I would like to leave this leave us with is this huge vision of the future of having this behavior testing. So what can we learn from genetic testing, which is used for screening newborns, discovering genetic factors, diagnosing disease, or even treating the disease, right? And getting through all these factors which are going to be passed on children. So we have all these different computational tools for managing our genetics. So how about if we start with thinking about behavior as being element of our health and quality of life, which is changeable, and then there are adequate technologies, because so far also these technologies are too difficult to use and they are not designed for different. They're also not cheap, like the wearables are not cheap. And anyway, how can we think from the future perspective of having this smartphone-based or personal technologies-based solutions, which are going to help us to not only screen, but also understand our behavior factors, which lead us to disease, and also help us to be healthier in the long term by means of providing even behavior change interventions, and recognizing what are, for example, risky behaviors which we affect with our social network, for example, right? So this is all future visions, and I'm very much welcome collaborations, and I really want to thank you also, all my students. Thank you. I would be very happy to get some questions.
Kate, thank you very much. Greatly appreciate it. And we're going into the Q&A session, as is our custom. And we're going to do about 15 minutes in regular time and then a half an hour in overtime. This call is being recorded. So I just want to remind you that if you participate in the Q&A part, right, that you're being recorded, and Maylin has some comments that she'd like to make about the availability of these recordings going forward. Maylin?
Thank you, Kevin. So starting in 2022, we will be making our PCI community calls available on our website. As you can see, this talk is really, really important for being people-centered. This information about quality of life, the ability to measure it, the review of the research going on in the world, which Katie has wonderfully curated. This is very important for those of us who care about having a people-centered internet. So this will be available publicly on our website. If you prefer not to be identified, you are welcome to not identify yourself and to change the name on your Zoom profile so that you can be anonymous. So this is just to give you the heads up on it. Thank you. Back to you, Kevin.
Yes, and I might point out that the way that Zoom records these is you might have this set up in a tile, right, where you can see everybody, but Zoom is only recording the person who's actively presenting or speaking. So you never see the tiling unless we specifically set it up that way to record in that mode. So Kate, we're ready to start questions. We've had quite a few contributions in chat from Doug. So Doug, why don't you jump in? You're got some interesting parallel thinking going on here.
Yeah, thank you so much for your presentation. Great insight. I'm part of Peter Diamandis' Abundance Digital Group as well. And of course, he has a focus on, health and the quantified self and so forth. So just your presentation was fantastic. So, if you had to do one thing that, say, hey, if you do this, and maybe sleep is the one thing, what would you, with this technology, what would be that one thing?
Self-care in the sense, and yes, a big part of this is sleep and physical activity, but not in a sense of like you have to go to the gym to do this thing, but to do something which makes you happy. So there's also a relation to psychological health. Yeah, so spend the awake time and count this, what Barbara Fredrickson's pointing out, the moments of positivity, right? When you feel good. And it could be related to doing physical activity. It could be also related to social interactions. Yeah, it's positive. So you need to leave the people who are not making you feel well. And it could be your own family members, unfortunately, somehow manage it differently. Yeah, so moments of positivity in the wake state, and then sleep. Yeah.
Well, I'm looking forward to looking at your presentation in detail, especially I think you mentioned about 40 or 50 different indicators of positive health, mental health. I'd like to look at that. One comment is when I give presentations to students, and I give it to high school students once a year, and I talk about the Gartner study on the different types of intelligence. And,
yes.
There's 9 different types of intelligence. And, in our society, so much we're focused on word intelligence or mathematical intelligence, and if you do well in those, then, you typically have a good job. But so important is emotional intelligence, social intelligence, self-intelligence, the 9 different types of intelligence. And unfortunately, I have a friend whose daughter is really struggling with emotional intelligence, and she's in a hospital right now because of that, of mental health issues. And, it's like, how do we, just like we teach mathematical intelligence and language intelligence, how do we help, give healthy, emotional intelligence so people, can navigate the world?
Yeah, that's where it is. What makes you feel good and comes in, and also the awareness of the influence of your daily life behaviors and other people. And I love to see this 9 types of intelligence. Yes, I remember I've seen it somewhere. And then the question will be also how this, how the data, passively collected data could feed some kind of evaluation and then help, and then the technology design interventions would help to improve this particular types of intelligence, or maybe not. Maybe some of them are just like, we don't need to be superhumans expert in all these different types of intelligence, right? But maybe there's some levels to which you want to strive or improve. So it's what's pathological also, right? Where's the threshold, and what you could want to improve, what you can improve also. You know,
right.
that would be super interesting. Yeah.
Yeah, I'm a technologist, but at the same time, the best way to help my emotional intelligence is to take a walk in the woods.
Right. Bravo.
Yeah, and how do we navigate our world? I wrote a blog, Are You Smarter Than Your Grandparents? And what is goals, what is intelligence, and what is a life well lived? I was kind of exploring those ideas. The comment was on using artificial intelligence to help you with all the 9 intelligences. So like instead of artificial intelligence, is intelligent augmentation. How do I use the technology out there to augment those 9 types of intelligence, so that I have goals and I have a better life experience.
Yeah. And then
Very
you
good.
rank them, right? What's important for you.
Doug, thanks for that. I have a question. When you were near the end, you were showing that diagonal chart where there are physical measures and then there were behavioral measures that you were thinking about. We've increasingly gone from, at least in the physical sense, from intermittent to continuous data feeds, whether they're from the human body, from the environment, IoT, rich environments. What do you imagine would allow you to go from intermittent inquiry to continuous, data feeds in the behavioral world?
Oh, it's such a good question. Yes. So first of all, you have
something short of Elon Musk's Neuralink in our heads.
Yeah, it's an excellent question, but you know what? It's also, I know people and athletes. I know athletes who are so aware of their body that they have this built-in. It's so intuitive that if I tell them, you know what, I would like to measure you because you're the best to learn from, and they're like, no, I don't need that. Don't touch me with your thing. Don't put things on me, right? So it's like the big part is awareness in this loop. Yeah.
I might suggest to you that because it's in your backyard, some of the best telemetry for athletes is being done by the Olympics, by the International Olympic Committee and their subcommittees. I've seen it in rowing, I've seen it in some other areas. So you may want to get in touch with them because their athletes generally are more willing to be on the bleeding edge of that kind of telemetry.
Yes, the challenge is that it's not then applied to chronically ill patients, which are, but yes, that's why I'm also one of the chapters, the learning from quantified self community, which is also bleeding edge practitioners from perspective of being patients as well as being individuals who are just curious about what technology can bring them, and it's like N of 1 experiments, which are then documented in their videos and online and in conferences. Yes.
Yeah, great. So Tony, I saw that you were making a comment in chat. We'd be delighted to have you join our conversation.
Thank you. Terrific insights. And I'm curious to know the age group that was selected for this data.
Boom. In general, it was healthy adults. So like for the book, right? For our own research, we do have healthy adult participants. I'm trying to avoid to use our students, as some of my colleagues notoriously do, unfortunately, and the other labs. But nevertheless, we have this living lab of adults, individuals being affiliated with the lab and being there for contributing to the studies. And then we have some clinical cases. So we look at my papers, and I apply these technologies in patients. And anyway, but for the book, the specific feedback for the authors was looking for self-reports for healthy adult individuals for diagnostic or screening purpose, no liver cancer, quality of life, pain scale or something, because then it would explode. And then, yes, all over the world, be as inclusive as possible. And some of the book chapter authors have been really excellently conducting systematic literature review for this self-reports and for technology reports, but not all of them, unfortunately. But still, I think I was very much motivating them to include as much as possible technologies and self-reports for healthy adult individuals across the world.
Outstanding.
I have a question, Katie. How much of this research is only just done in your lab? Are there other quality of life labs around the world? It's so important. And so I'm wondering, what is the spread of this?
Wow, that's such a fascinating question. And I hope there will be another level of decoding. That would be great. So first of all, I would like to say that many of our computer science lab focus on one or two aspects. And as at the beginning, somewhere when we started to have Android and we could get the data from Android and then first Fitbits and things, there was a lot of physical activity. Everybody was doing physical activity, then later on a bit of sleep, and then moving to sleep and stress and other states. And then it looks like some of my colleagues, I have an impression they moved to the other thing, and the overall field is digital health. And then from more clinical perspective, it's much more silos. Like if somebody is an expert in cancer, and there will be assessment of pain via different types of technologies. But again, that was not specifically documented in the book. There was epidemiology studies mentioned, and there will be some one specific aspect of stress, or there was something about, for example, suicidal prevention with respect to mental health, and silos, a lot of silos. And then yeah, I would love to, I don't have this answer how many labs are having visionary view like mine. I really would like to have a validated holistic model of quality of life, which will be also maintained in time. That's also a problem with research. You can do like a cross-sectional study, you can publish a paper, and it's like, okay, let's move to the next thing. That's also a problem, right? There is no maintenance sometimes. So, but the reference papers and also the authors are from all over the world, from Australia and the United States, Europe, and experts from all over the world. And then reference papers also from all over, yeah.
I have a follow-up question because you're there in Geneva. I think, the WHO has been under intense pressure with COVID, and it looks to me that WHO will somehow restructure, have a new sense of purpose, if not immediately, over the next 10 years. Do you see actually bringing quality of life into the WHO measures? Because then it seems that WHO could actually do a better job in monitoring and perhaps preventing things rather than waiting until we fall into these disasters.
Yes, thank you very much. Excellent question. I have been already very much volunteering as a regional expert in e-health, so IEEE and WHO, so sorry, IEEE, ITU, International Telecommunication Union, which is the agency for more the telecommunication aspect, as I come from computer science. And then we've been having discussion of how do we have this metrics derived from everybody's phone, right? From the perspective of having the device already in the hands of the individuals. And unfortunately, I have not yet reached to a right person at World Health Organization to tell you that I have path forward. Also, as you said, they're really busy with COVID, and being here in Geneva is not that helpful right now at this particular moment, but I'm going to make it there. And so far we've been in touch with a person who is in digital health and much more focused on the smoking cessation. And for example, she was contributing to our seminar last year, September. We had an online seminar. So I'm going for it. Definitely, I would like to help, specifically because the whole framework, the theory I'm using is the one developed by World Health Organization, which is the quality of life assessment. So yes, if anybody can help me with reaching out to the right person, I will be very happy. I do know that they are not sponsoring any particular projects. They do not have really money for this, but they can be very good in helping to also raise the money together and also discuss what are the specific aspects and how to disseminate the research. Yes.
Great.
I'd like to actually notice that Deb Gale is here with us, and she has been working on longevity and the age of no retirement. And Deb, perhaps you could say a little bit about what you're doing and whether or not my inquiry for the both of you, Katie and Deb, is there a potential for collaboration? Deb.
I was actually, Maylin, I was just writing you a private note about this because moments of positivity in human relationships are clearly linked with purpose. And my whole gig at the age of no retirement is about helping people to discover or rediscover their purpose, because all our research has pointed to the fact that when the most powerful motivating force in humans is they crave love, but secondly, they crave purpose. And when you can align purpose with passion, and then align that with the ability to make money, you've got the whole, you've got everything sorted. And right now, we are focusing primarily on people in early or just retired, because they are the people that are waking up to the fact that given the current narrative on retirement, people have a very long runway ahead with not very much to do, and they've been discounted by society. So we have to figure out a way for these people to refine their mojo and to reanimate this fallow talent pool of all the acquired talent, experience, wisdom, networks that all of us who have been working for some time have basically accumulated. So it's all about rekindling purpose along with purposeful non-retirement, but not eliminating the intergenerational necessity to make people be alive and awaken to their purpose. Sorry, that was a long soliloquy.
Beautiful. Yes, totally agreed. Yes.
But there's so much, what you were talking about, Katie, is you can't have positivity in human relationships unless you feel empowered. You have to have some purpose. You have to have some skin in the game, and purpose is always just beyond yourself.
Yeah. And awareness, what makes you feeling so, right? Also.
Correct. And finding out what it is that makes you, what makes you tick. What is your, we link it to three things. Our purpose framework is about, your identity, because of course your identity is who you are and what makes you do what you do. But if you can figure out what you want to do and align that with your intention, so identity, intention, and then figure out a way to activate those intentions, then you've got the whole thing.
Yes.
That's great. I'm glad that you folks are have intention to connect.
Yeah,
Katie,
thank you, Kevin.
That's great. Kate, I just put something into the into chat. The first time that I ran into the term quality of life and quality of life indicators, the context was much larger. The Calvert-Henderson quality of life indicators include employment, energy, environment, health, human rights, income, infrastructure, national security, public safety, recreation, shelter, and education. So it's a very comprehensive view. I'm wondering where quality of life is currently being used as a term and whether it spans what you're currently looking at in this larger context. Are there still people that are zooming out, right, the way that Hazel Henderson did with Calvert?
Let me say it depends. So again, when you think about economic value and GDP and aspects of financial aspects of the society, then they do zoom out, and there will be different axes. Like, for example, you in this particular indicators lacking like internet access. Is there? Okay, infrastructure, you may say. So like there will be specific indicator of internet access. Then when you try to compare this one with all the World Health Organization, there's some mapping, there's some grouping. I could see that they're quite complementary, and the 24 by World Health Organization are much more detailed. There's like, for example, there's personal security and safety versus the environmental security and safety. Yeah, also it's here. Yes. Anyway,
so is it just a matter of focus that your work is more related to quality of life for a person, where this other
correct.
body of
So,
knowledge
yeah,
is more like quality of life for a society?
That is correct. So that's what I try to point out, like pointing out, like what's the context of, there are people defining psychological terms and economics terms, and developmental terms, and what are the other terms? There were economics, policy science was different, OECD was different, and then the more like a medical sciences, the individual, focus on the individual. Yes, and then I would like to tell you a story, and for anybody also, it's very interesting to see, in case you're developing new drug in medical sciences, and you say you would like to have a quality of life claim that it improves quality of life, you would use some instruments like SF36, the EQ5D, like the keywords are as follows. Then you pay licensed for using this, or the self-reported questionnaire, and some of the questions are not related to public safety or something, or any of those 24. It will be more depression, pain, daily functioning, the activities of daily life, and like the basics of you as a human. And then you could, if you say that you improve this particular, in some of this domain, your drug improves this functioning, this just basic functioning of you can sleep better, you have less depression, you have less pain, then you can put in a claim. I mean, that's what I'm saying at large. There's a huge FDI and European Medical Association workflow and pipeline to follow, but generally I'm saying these are few questionnaires, few very specific questionnaires which are accepted by these agencies, and also very specific ways of following with the patients when you develop a new drug and you have a claim that it improves quality of life.
No, thank you.
Much more individual view. Yeah.
So this ends our formal first hour. All right. And then we want to thank you for being with us,
Thank you.
Kate. We're going to continue. We're going to stop recording, but we're going to continue with our conversation for an additional half an hour for those who want to stay. Mei Lin, thank you so much for
Thank you.
bringing Kate to our